The soldier had been lying in the trench for 4 days. The shrapnel wound in his thigh had turned black at the edges. The stench told the medics everything they needed to know. Gas gangrene. In 1917, that diagnosis was a death sentence. The bacteria Clostridium perfringens, lurking in soil fertilized by centuries of manure, had found its way deep into torn muscle. The toxins were spreading. Without radical amputation, the man would be dead within hours. But when the stretcher-bearers finally pulled him from the mud and brought him to the field hospital, something impossible had happened. Beneath the crust of dried blood and the writhing mass of maggots that had infested the wound, the exposed flesh wasn't gray and putrid. It was pink, clean, alive. Dr. William Baer stood over the soldier, staring at tissue that should not exist. He had seen hundreds of gas gangrene cases. He knew what they looked like. This wasn't one of them. The maggots had eaten everything dead and left everything living untouched. Before we go further, if you appreciate deep dives into medical breakthroughs that defied conventional wisdom, hit that like button. This story gets darker before it gets better. The killing fields of World War I. The Western Front was not just a battlefield. It was a bacterial incubator. The trenches carved through farmland that had been cultivated and fertilized for generations. Every shovelful of earth contained dormant spores of Clostridium species, ancient bacteria that thrived in the absence of oxygen. When high-velocity shells and shrapnel tore through human tissue, they carried fragments of uniforms, dirt, and manure deep into the wound cavity. The injuries were catastrophic. The Minié ball of the American Civil War had been replaced by explosive ordnance that didn't just pierce flesh, it shattered bone, macerated muscle, and created pockets of dead tissue. These necrotic zones became anaerobic chambers, perfect environments for Clostridium to germinate and multiply. The bacteria produced toxins that caused excruciating pain, gaseous swelling that crackled under the skin, and rapid muscle breakdown called myonecrosis. Surgeons faced an impossible calculus. To save a life, they had to remove all contaminated tissue. The surgical doctrine was brutal. Cut until you see healthy bleeding muscle, wide excisions, no primary closure. Leave the wound open for days, hoping serial cultures would eventually show the infection had cleared. Even with meticulous debridement, the mortality rate was staggering. During World War I, approximately 100,000 German soldiers died from gas gangrene alone. Dr. William Stevenson Baer had witnessed this carnage firsthand. Born in 1872, he had trained under some of the finest surgical minds in America before the war. By 1917, he was serving as a military surgeon on the front lines, and he had seen enough young men die screaming from gangrene to fill a cemetery. Then came the two soldiers who changed everything. The observation that shouldn't have worked. They had been missing for nearly a week. When they finally stumbled back to camp, both men were in shock, feverish, and covered in filth. One had a neglected fracture of the femoral bone. The other had massive abdominal wounds. Both injuries were swarming with fly larvae, fat, writhing blowfly maggots that had hatched in the warm, rotting tissue. Baer expected to find sepsis, purulence, and the telltale signs of systemic infection. He expected to amputate or to pronounce them dead within hours. Instead, he found wounds displaying the most beautiful pink granulation tissue that one can imagine. There was no fever, no purulence, no sign of the overwhelming bacterial infection that should have killed them both. The maggots had done something that no surgeon, no antiseptic, and no surgical technique had managed to achieve on the Western Front. They had selectively consumed every scrap of dead, infected tissue while leaving the living flesh completely intact. Baer was not the first to notice this phenomenon. During the American Civil War, Confederate surgeon John Forney Zacharias had documented similar observations in soldiers with gangrenous wounds. Centuries earlier, Battlefield surgeons like Ambroise Paré and Dominique Jean Leray had remarked on the curious healing properties of maggot-infested wounds. But these were anecdotes, folklore, the kind of battlefield wisdom that respectable surgeons dismissed as desperation medicine. Baer, however, was a scientist. He didn't dismiss the observation. He filed it away, a puzzle piece that didn't fit the prevailing theories of antiseptic surgery. And when the war ended, he carried that puzzle piece home to Baltimore. The bone infection that wouldn't heal. After the war, William Baer returned to Johns Hopkins University, where he had been appointed the founding chairman of the Department of Orthopedic Surgery. It was a prestigious position, but the work was often heartbreaking. His patients weren't soldiers anymore. They were children. Osteomyelitis, chronic bone infection, was a scourge of pediatric wards in the 1920s. The bacteria, usually Staphylococcus aureus, would burrow deep into the bone marrow, forming abscesses that no amount of surgical drainage could fully clear. The children would undergo operation after operation. Surgeons would cut, drain, pack the wound with antiseptic gauze, and wait. The infection would flare again, more surgery, more pain. Some children spent years in hospital beds, enduring recurrent suppurating wounds, watching their childhoods vanish into a cycle of failed treatments. The surgical arsenal was limited. Antiseptic solutions like carbolic acid could sterilize instruments and skin, but they couldn't penetrate deep into necrotic bone. The Orr method, immobilizing the limb in a plaster cast and allowing the wound to drain, had shown promise, but it was slow and unpredictable. Many children faced amputation. Some died. Baer thought back to those 2 soldiers in the trenches. He thought about the pink granulation tissue, the absence of infection, the precision with which the maggots had cleaned the wounds, and he decided to try something that would make him the laughingstock of American surgery. In the mid-1920s, at Baltimore Children's Hospital, William Baer introduced live blowfly larvae into the suppurating bone infections of his young patients. He started small, breeding the maggots on a hospital windowsill, ensuring they came from sterile fly eggs. He placed them directly into the infected wounds and waited. The results were extraordinary. Infections that had resisted months of conventional treatment began to clear within 6 weeks. The maggots consumed the necrotic bone and soft tissue with surgical precision, leaving behind clean, granulating wounds that finally began to heal. But then 2 of his patients developed tetanus, and both of them died. The tetanus crisis and the birth of sterile maggots. The tetanus deaths were a catastrophe. Clostridium tetani, the bacterium responsible for tetanus, produces spores that can survive on fly larvae. If the maggots weren't completely sterile, they could introduce new infections even as they cleaned away the old ones. Baer could have abandoned the technique. Many surgeons would have. The risk was too great, the optics too damaging. But Baer understood something crucial. The principle was sound. The execution needed refinement. He developed a protocol for producing truly sterile maggots. Adult blowflies were captured and placed in sterile containers. They laid their eggs on sterile meat in a controlled environment. The eggs were then surface sterilized with antimicrobial solutions before being allowed to hatch. The resulting larvae were raised in sterile conditions, fed only sterile substrates, and monitored for any contamination. The process was expensive and labor-intensive. Each batch of medical-grade maggots required meticulous quality control. But it worked. Subsequent patients treated with sterile maggots did not develop tetanus. The infections cleared without introducing new pathogens. By 1929, Baer was ready to present his findings to the medical community. At the Interstate Medical Association meeting in Detroit, he described his technique in detail. He presented case studies, outcome data, and his protocol for producing sterile larvae. The reaction was not what he had hoped for. The medical community declares war. To understand the hostility Baer faced, you have to understand the culture of early 20th century surgery. The previous 50 years had been defined by the germ theory revolution. Surgeons had fought brutal battles to establish antiseptic techniques. Joseph Lister's carbolic acid sprays, the introduction of sterilized instruments, the obsessive scrubbing protocols, all of it was designed to keep foreign contaminants out of the surgical field. And now, William Baer was proposing to deliberately introduce live insects, creatures universally recognized as vectors of disease, directly into open wounds. One of Baer's colleagues later recalled that the medical community viewed maggot therapy as a colossal medical joke, too ridiculous even to be taken seriously. The derision was immediate and widespread. Physicians saw it as a regression to medieval medicine, abandonment of scientific progress. Dr. Walton Martin, a prominent New York surgeon, was particularly scathing. He dismissed Baer's claims entirely, emphasizing that flies had justly been considered the most dangerous of all the disseminators of pathogenic microorganisms. How could any rational physician deliberately place maggots into a wound? It violated every principle of modern hygiene. The criticism went beyond scientific skepticism. There was a visceral disgust, a sense that Baer was violating the dignity of his patients by subjecting them to insect infestation. Maggots were associated with filth, decay, and death. They belonged in garbage heaps and corpses, not in sterile hospital wards. Baer faced institutional resistance as well. Hospitals were reluctant to allocate resources to breeding flies. The idea of maintaining insect colonies in medical facilities struck many administrators as absurd. Some questioned whether the technique could ever be scaled beyond a handful of experimental cases. But Baer had something his critics didn't: results. And those results were starting to become impossible to ignore. The 48-hour miracle. The breakthrough wasn't just that maggot therapy worked, it was how fast it worked. In conventional wound debridement of the 1920s and 30s, clearing necrotic tissue from a chronic wound could take weeks or even months. Surgeons would perform repeated excisions, each one requiring anesthesia, each one removing small amounts of dead tissue while inevitably taking some viable tissue as well. Between procedures, the wounds would be packed with gauze soaked in antiseptic solutions. Patients endured prolonged hospital stays, repeated trauma, and the constant risk of introducing new infections with each surgical intervention. Maggot therapy collapsed that timeline. Studies conducted in the 1930s documented complete debridement in as little as 3 days. But even more striking were the observations at the 48-hour mark. In one documented case of Fournier's gangrene, a devastating necrotizing fasciitis of the genitals and perineum, a patient received a single 48-hour cycle of maggot therapy. Approximately 300 larvae were applied directly to the necrotic tissue. After just one cycle, clinicians observed a notable decrease in wound exudate and odor. Granulation tissue, the pink vascularized tissue that indicates healing, began to appear along the wound bed. This wasn't gradual improvement, this was transformation. Within 48 hours, wounds that had been black, foul-smelling, and crawling with bacteria were showing signs of active healing. Another patient with extensive Fournier's gangrene required 8 cycles of maggot therapy over several weeks. Each cycle used approximately 500 larvae. After the final cycle, no necrotic tissue remained. Wound cultures were clear of pathogens. The wound base was covered with healthy granulation tissue. The patient avoided the extensive reconstructive surgery that would otherwise have been necessary. But here's what made these results truly revolutionary. The maggots didn't just clean faster than conventional methods, they cleaned more precisely. The microscopic surgeons. To understand why maggot therapy worked so well, you need to zoom in to the microscopic level. The larvae Baer used, primarily Lucilia sericata, the common green bottle fly, are extraordinarily specialized feeding machines. Each larva possesses a pair of curved mouthhooks that it uses to scrape and tear at the surface of necrotic tissue. But the real magic happens chemically. The larvae secrete a potent cocktail of enzymes directly onto the wound bed. These secretions contain at least 3 classes of proteolytic enzymes: serine proteases, aspartyl proteases, and metalloproteases. These enzymes break down the proteins that hold necrotic tissue together, liquefying dead flesh into a nutrient-rich fluid that the larvae can then ingest. The process is called extracorporeal digestion. The maggots digest their food outside their bodies, then consume the resulting liquid. But here's the critical part. These enzymes are highly selective. They aggressively attack dead tissue while leaving living cells virtually untouched. The biochemical markers that distinguish necrotic tissue from viable tissue guide the enzymatic activity with a precision no human surgeon can match. The larvae also secrete antimicrobial compounds. Their excretions contain ammonia, which acts as a weak disinfectant, raising the pH of the wound environment. More importantly, they produce a range of antimicrobial peptides, small proteins that directly kill bacteria. Research has identified multiple antimicrobial peptides in Lucilia sericata secretions, with names like LSR-CEC1, LSR-CEC2, and LSR-Stomox1. These peptides show potent bactericidal activity against common wound pathogens including Staphylococcus aureus, Streptococcus pyogenes, Clostridium species, Proteus vulgaris, and even Salmonella. One study found that heat-treated larval secretions, heated to 110 Rads for 20 minutes, retained their antibacterial activity. This meant the antimicrobial effect wasn't just from the ammonia or other volatile compounds. There were stable, heat-resistant antibacterial factors in the secretions themselves. The maggots were doing 3 things simultaneously: mechanical debridement with their mouthhooks, enzymatic digestion of necrotic tissue, and chemical disinfection of the wound bed. No other treatment modality could accomplish all 3 with such precision and speed. By the mid-1930s, the clinical evidence had become overwhelming. The boom years. Despite the initial ridicule, maggot therapy began to spread through American hospitals. The Laduro Pharmaceutical Company saw the commercial potential and began breeding sterile maggots on an industrial scale in the 1930s. Medical-grade larvae became available for purchase, eliminating the need for individual hospitals to maintain their own fly colonies. Publications began to accumulate. Single-case reports were followed by larger cohort studies. While these studies didn't employ the randomized controlled trial methodology that would become standard decades later, they provided what the medical community of the 1930s considered rigorous evidence: large numbers of patients, documented outcomes, and mathematical data. Surgeons began applying maggot therapy to conditions beyond osteomyelitis. Diabetic foot ulcers, pressure sores, traumatic wounds, and post-surgical infections all showed dramatic improvement with larval debridement. The technique was particularly valuable for patients who were poor surgical candidates, those too frail for repeated operations, or with wounds in anatomically complex locations where surgical debridement risked catastrophic tissue loss. On April 17, 1930, William Baer stood before the United States House of Representatives Committee on World War Veterans legislation. He presented his vision for using maggot therapy to treat the thousands of long-term convalescent patients still suffering from war-related infections in veterans' hospitals. The committee's response was enthusiastic. Baer had won. Maggot therapy had moved from ridicule to respectability. Medical journals published detailed protocols. Surgeons who had once mocked the technique were now requesting sterile larvae for their own patients. It seemed like the beginning of a new era in wound care, but the era would last less than a decade. The antibiotic revolution. In 1928, Alexander Fleming noticed that a contaminating mold had killed bacteria in a petri dish. By the late 1930s, Howard Florey and Ernst Boris Chain had purified the active compound, penicillin. The first clinical trials during World War II showed astonishing results. Battlefield infections that would have required amputation or killed the patient outright were cured with injections of the new drug. Sulfa drugs arrived around the same time, offering another weapon against bacterial infections. For the first time in human history, physicians could kill bacteria inside the human body without surgery, without debridement, without maggots. The appeal was obvious. Antibiotics were clean, chemical, easily standardized, and didn't require patients to endure the psychological trauma of having live insects placed in their wounds. By the 1940s, maggot therapy was in rapid decline. In 1945, microbiologist Milton Wainwright described maggot therapy as relegated to a historical backwater of interest more for its bizarre nature than its effect on the course of medical science. He suggested it was a therapy the demise of which no one is likely to mourn. William Baer did not live to see this decline. He died in 1931, just as maggot therapy was reaching its peak of acceptance. He had spent the final years of his life training the next generation of orthopedic surgeons at Johns Hopkins, many of whom would go on to become leading practitioners of the 20th century. But his most controversial innovation, the one that had brought him ridicule, vindication, and ultimately a place in medical history, appeared to have died with him. For 40 years, maggot therapy existed only in historical footnotes and occasional anecdotes from elderly surgeons who remembered the old ways. Medical students learned about it as a curiosity, if they learned about it at all. But in the trenches and operating rooms of late 20th century medicine, a new crisis was brewing, and it would bring the maggots back. The return of gangrene. By the 1980s, physicians were confronting a problem that would have horrified William Baer: wounds that antibiotics couldn't heal. Antibiotic resistance had been recognized as a theoretical concern almost as soon as penicillin entered widespread use. But by the 1980s and 90s, it was no longer theoretical. Methicillin-resistant Staphylococcus aureus, MRSA, vancomycin-resistant Enterococcus, VRE, and multi-drug-resistant strains of Pseudomonas and Acinetobacter were spreading through hospitals. Patients with chronic wounds, diabetics with non-healing foot ulcers, paraplegics with pressure sores, vascular disease patients with ischemic tissue, were facing amputations or death because their infections wouldn't respond to conventional antibiotics. Surgical debridement helped, but it was often insufficient. The bacteria would return. The wounds would recur. A few maverick clinicians remembered Baer's work. They began experimenting with maggot therapy again, initially as a treatment of last resort. The results mirrored what Baer had seen 50 years earlier. In 2004, researchers published a randomized controlled trial comparing maggot debridement therapy to conventional hydrogel dressings in patients with diabetic foot ulcers and leg ulcers. The study measured debridement at 2 weeks and at the end of the treatment period. Maggot therapy achieved significantly faster and more complete debridement at both time points. It was also associated with accelerated growth of granulation tissue and wound epithelialization at just 4 weeks. Economic analyses showed that maggot therapy could save the United Kingdom approximately $50 million annually if used for just 30% of non-healing diabetic ulcers requiring debridement. The cost savings came from reduced surgical procedures, shorter hospital stays, and fewer amputations. In 2005, the U.S. Food and Drug Administration officially approved medical-grade maggots as a medical device, not a drug, not a biological product, a device. The classification was oddly appropriate. The maggots were tools, living tools, but tools nonetheless. Precision instruments for cleaning wounds that human hands and human chemistry could not adequately address. The modern battlefield in 2024. Reports emerged from Ukraine of gas gangrene cases appearing in wounded soldiers. The trench warfare conditions that characterized World War I had returned, and with them, the same bacterial infections that had killed 100,000 German soldiers a century earlier. The cycle had come full circle. The battlefield conditions that led William Baer to first observe the effects of maggots in 1917 were creating the same wounds in 2024. But now, physicians had a tool that had been proven in randomized trials, approved by regulatory agencies, and produced in sterile laboratory conditions. Medical-grade maggots are now produced by specialized companies that maintain colonies of Lucilia sericata under stringent quality control. The larvae are shipped to hospitals in sterile containers, ready to be applied to wounds. Clinicians use them for diabetic ulcers, pressure sores, venous leg ulcers, traumatic wounds, and necrotizing fasciitis. The application protocols have been refined. Maggots are typically applied in cycles of 48 to 72 hours. Between 5 and 10 larvae per square centimeter of wound surface is the standard dosing. The larvae are contained using specialized dressings that prevent them from migrating while allowing them to breathe and secrete their enzymes. Modern research has also explored whether the active compounds in maggot secretions can be isolated and used without the live insects. Pharmaceutical companies have experimented with extracting the antimicrobial peptides and proteolytic enzymes, attempting to create synthetic versions that could be manufactured and applied like conventional drugs. But here's the problem: the whole organism performs better than the sum of its parts. Isolated enzymes don't debride as effectively as living larvae. Synthetic antimicrobial peptides don't disinfect as thoroughly. The coordinated action of mechanical scraping, enzymatic digestion, and chemical disinfection, all regulated by the living larva in response to the wound environment, has proven difficult to replicate in a laboratory. This was the same challenge that Baer's contemporaries faced in the 1930s. The orientation of pharmaceutical research toward patentable, mass-producible compounds created pressure to replace the maggots with something that could be synthesized in a factory. But the biological complexity of the larval therapy system resisted that reduction. The maggots remain more effective than any synthetic alternative yet developed. The human element. It's worth pausing to consider what it must have been like to be William Baer's patient in the 1920s. You're a child with a bone infection. You've been in the hospital for months. You've undergone multiple surgeries. The pain is constant. You've watched other children in your ward die or leave with amputated limbs. The surgeons tell your parents there's nothing more they can do. Then, Dr. Baer comes to your bedside with a vial of squirming white larvae and tells you he wants to place them in your wound. The psychological burden was immense. Parents had to consent to a procedure that sounded like something from a medieval torture chamber. Patients had to endure the sensation of insects crawling in their open wounds, even though the larvae themselves don't cause pain because they only consume dead tissue that has no nerve endings. But here's what the patient saw. Wounds that had been suppurating for months began to close. Infections that had resisted every other treatment cleared. Children who had been facing amputation or death went home with their limbs intact. The soldiers William Baer treated during World War I didn't have a choice. They had been abandoned in no man's land with festering wounds, and the maggots found them by instinct. But those soldiers survived because of that chance infestation. They walked back to camp when they should have died in the mud, and the modern patients, the diabetics with foot ulcers that won't heal, the paraplegics with pressure sores eroding down to bone, the infection patients who've exhausted every antibiotic in the pharmacy, they choose maggot therapy because it works when nothing else does. What Baer got right. William Baer understood something that many of his critics missed. Nature has been solving the problem of decomposition for millions of years. Blowfly larvae evolved to consume dead tissue efficiently while avoiding living cells, because living cells fight back and dead cells don't. That evolutionary specialization made them perfect instruments for surgical debridement. He also understood that disgust is not a scientific argument. The medical establishment's visceral revulsion to the idea of maggots in wounds was a psychological barrier, not an empirical one. Baer did the experiments, documented the outcomes, and forced the profession to confront the data. And he understood that effective medicine doesn't have to be complex. In an era when surgery was becoming increasingly technical, when biochemistry was revealing the molecular mechanisms of disease, when pharmaceutical chemistry was racing toward the antibiotic revolution, Baer looked at a simple biological system and recognized its medical potential. The irony is that his critics were partially right. Flies are disease vectors. They do carry pathogens. Baer's initial attempts did kill 2 patients with tetanus. But instead of abandoning the approach, he solved the technical problem. He developed sterile maggot production protocols that eliminated the risk while preserving the benefit. That's the mark of a true innovator, recognizing when a failure is a problem of implementation rather than a flaw in the underlying principle. The legacy today, maggot therapy occupies a strange position in medicine. It's FDA-approved, evidence-based, and supported by randomized controlled trials. Major wound care centers use it routinely. Medical schools teach it as a legitimate treatment option. But it's still often positioned as a last resort therapy, something to try after everything else has failed. Part of this is economic. Maggot therapy requires specialized suppliers and trained personnel. Part of it is cultural. The psychological barrier remains for many patients and physicians. Yet the clinical data suggests it should be used much earlier in treatment algorithms. Studies show that early application of maggot therapy reduces the total number of surgical procedures required, shortens hospital stays, and improves outcomes. Waiting until a wound has failed multiple conventional treatments means the tissue damage is more severe, the bacterial burden is higher, and the healing process is more compromised. The same pattern Baer faced in the 1920s persists today, a therapy that works better and faster than alternatives, held back by institutional inertia and aesthetic objections. But here's what can't be denied. When a wound is gangrenous, when the tissue is black and necrotic, when the bacteria have formed biofilms that antibiotics can't penetrate, when surgical debridement would require removing so much tissue that reconstruction becomes impossible, that's when you place 300 sterile Lucilia sericata larvae on the wound bed and wait 48 hours. And when you remove the dressing after those 48 hours, you see what William Baer saw in that French field hospital in 1917, clean, pink, granulating tissue where death had been. The maggots don't care that they're disgusting. They don't care that they violate aesthetic norms or that they make people uncomfortable. They do what millions of years of evolution designed them to do, consume dead tissue with ruthless efficiency, leaving life behind. The bigger picture. The story of maggot therapy is really about how medicine decides what's acceptable. For centuries, physicians used mercury compounds, bloodletting, and trepanation because those were the established practices. When germ theory arrived, it faced fierce resistance from doctors who found the idea of invisible microorganisms absurd. When Ignaz Semmelweis suggested that doctors should wash their hands between performing autopsies and delivering babies, he was ridiculed into obscurity and died in an asylum. Medical progress doesn't follow a smooth upward trajectory. It lurches forward in fits and starts, driven by individuals who are willing to endure mockery for doing what the data suggests will work. William Baer was one of those individuals. He saw something impossible, investigated it rigorously, refined the technique until it was safe, and then defended it against a profession that considered it a joke. He died before he could see maggot therapy fully vindicated. He died before antibiotics made his technique seem obsolete. and he died long before antibiotic resistance brought the maggots back to respectability. But every patient today who avoids amputation because maggot therapy cleaned a wound that antibiotics and surgery couldn't heal, every diabetic who keeps their foot, every burn victim who avoids sepsis, every soldier who survives necrotizing fasciitis, they're all beneficiaries of that impossible observation Bear made in a trench in France. 2 soldiers covered in mud and maggots should have died. They lived. And because Bear paid attention to that impossibility, thousands of others have lived too. The medical establishment banned his technique by rejecting it, mocking it, excluding it from respectable practice. But they couldn't ban the fact that it worked. And when you're facing gangrene, when the tissue is dying and the clock is running down, facts matter more than respectability. 48 hours. That's how long it takes for 300 sterile larvae to turn a necrotic wound into living tissue. 48 hours that were impossible until William Bear proved they weren't. That's the legacy. Not the disgust, not the controversy, not the decades of obscurity. The legacy is measured in wounds healed, limbs saved, and lives extended by a therapy that shouldn't work, but does. If you made it this far, you've got the patience for deep research and uncomfortable truths. Subscribe for more stories of medical breakthroughs that defied conventional wisdom. The next one involves battlefield surgery, experimental anesthesia, and a technique that reduced mortality from 85% to 15%, but was suppressed for political reasons. The maggots are still out there, in sterile vials, in wound care centers, waiting to do what they've always done: clean the dead, preserve the living, prove that sometimes the most effective medicine is the one that makes us most uncomfortable.